पापा पढ़ाई अरे Good evening, Ganesh.
Good evening, sir. अच्छा program है.
Yeah. So when did you shifted to Hinduja?
Hinduja, I shifted in like end December, last few days.
Okay.
Last few days.
So when are your OPD timing? Every day?
Every day, sir. मतलब Monday to Friday, so every day, and Saturday, since it is near, I said keep. If patient walks in, let me know. If I am around, I'll come. Saturday अभी रखा नहीं है मैंने.
So Monday to Friday, you have got your own cabin. Full day you can see the patient. Anytime you can see. Anytime you can just.
Hi Ganesh.
Good evening, sir. कैसे आहात तुम्ही?
Good evening. Good evening. Hi Gaurang.
Hi. Good evening.
I'm going to be
Nice
there.
see you.
चलो
Nice to see
मिलते
you,
हैं.
sir.
पर गणेश का नाम नहीं था ना, गणेश का चीफ.
है
नहीं
ना?
है सर, मेरा
आप
नाम ऑनररी मेंबर हुई है
नहीं।
ग्रुप का सर.
नहीं आप बराबर देखो.
हाँ.
देखो बराबर देखो आप.
अच्छा.
लेफ्ट हैंड साइड पे.
हाँ नहीं मेरे को लगा ये अभी.
No, not this one. The new one.
अच्छा न्यू वन.
जिसपे लिंक है ना, on that link, on the left hand side there is a name of everyone.
Anyway, now तो अभी I am here only, तो चलो.
Good.
चलो.
Others have joined.
अरे 22 people are seen here.
I think
No, but other people have joined. Those who are giving presenting. Aparna.
Dr. Abhishek is there.
no, I don't think anybody has joined.
Aparna, Mahendra, and Menon, and
महेंद्र भी
Vashishtha.
नहीं है. महेंद्र को फोन करता हूँ.
yeah, I'll also tell you.
I have messaged Mahendra. I think they should join.
I joined.
चलो, then Mahendra चालू करते हैं ना. We'll introduce you.
एक मिनट रुकिए जरा. आई थिंक सर कॉल कर रहे हैं. हेलो. यस सर.
We have already 33 people. So
There is
Gaurang
some
sir
problem.
join करे, चालू करे. कि we wait. You want to wait 2 minutes?
Hi Ganesh.
Hi Santosh.
Hi Benin sir.
अरे Aparna is also joined. I think.
अरे मेरा वेबकैम जरा कुछ काम नहीं कर रहा.
ऐसा कैसे रिपेयर करो यार. ऐसे नहीं चलेगा. We want to see you.
अभी तो है तो लास्ट में आई कैन नॉट रिपेयर.
दूसरे फोन से ज्वाइन करते फिर. फोन से कैमरा दिखाओ.
सर फिर वो पीपीटी का दिखा पाऊंगा ना मैं.
मेरा वेबकैम चालू है लेकिन मैं ऑन नहीं करने वाली हूँ.
So how are you, Aparna? Good?
Good sir, how are you?
Good. I'm doing good.
अच्छा Aparna, thank you so much. And sir, thank you so much. Menon sir, just
Thank you.
accept
You both
our
have joined
invitation.
and you both
Only
will be
one
spending
call.
time with us. I
Yeah,
hope you
thank
all
you so
have
much.
had dinner.
Yes,
Aparna,
yes.
Santosh,
Yes,
Dr. Menon, you are all welcome. Thank you very much.
Vashishtha
Thank
has
you,
also
sir. Thank you,
joined.
sir.
Vashishtha
Thank you.
has joined. Vashishtha. He will
Vashishtha,
join a little later.
Vashishtha, I telephone him. he is little busy with some
No
COVID
problem.
patient.
So he
He
can
has
join a
got
little
something to
later
do.
only, sir.
So he'll either will join later or
Yeah,
he
yeah.
will tell one of his colleagues to, because everything is ready, so they will present it. And
Okay.
I think we have got almost 43 people, Ganesh.
Right, sir.
So
Okay.
I'll
So
just
no
yeah.
problem.
You can
So we
start.
start now. So
Yeah,
good
yeah,
evening,
we
everybody. आज गीते सर नहीं है ना अपने साथ?
His father died, na? So
I
he
know,
has
I know.
gone, and
Okay.
he told me that he will be little busy with his all the
Family.
ceremonies.
Yeah, no problem. So good evening, everybody, and we are right back at 9 o'clock. This clinic is quite famous now, and it goes on till 11:30. Hope today we finish all the 4 lectures in time, and we just had a few bladder cancer case presentations in the preceding Tuesdays, except for the last one where we had a PUJO. So we thought this would be a good finishing to the bladder cancer case presentation series. So we have eminent speakers today: Dr. Mahendra Pal, Dr. Aparna Katdare, Dr. Santosh Menon, Dr. Vashishtha Maniar. We have Dr. Abhishek Ghosh. So we begin with one of the maybe what problems the examiner saw here in case taking or talking, probably how to take and talk. So Dr. Mahendra Pal, professor in uro-oncology at Tata Memorial Hospital, having a very good experience and in uro-oncology as well as teaching. Mahendra has volunteered actually to help the students with telling them actually how you should go about a case in probably uro-oncology, and I think the same would be applicable in most other cases in urology if you do it in a systematic way, as we all have been discussing all this while. So I invite Dr. Mahendra Pal. Please, Mahendra.
Yeah.
We are waiting for your teaching.
Okay. Thank you, sir. Sir, anybody stop the screen sharing? The other person?
Okay, I'll
Host,
stop, sir. You
host,
take over.
please. Acha. Yeah.
Okay. So, are slides visible?
Yes, sir.
Yes, almost. Yes.
Okay. So, I'm just limiting my talk as just case preparation and what thing you should cover when you prepare the case in oncology, and I will compare how is it similar with the benign diseases and how it is different from the malignant disease. So what I take personally as a history taking and diagnosis is that patient is like a sudden riddle once he comes in OPD, because we don't know which patient is coming in which problem, something like a riddle, and we have to find out the most accurate answer as early as possible. And the tools we have in the OPD, where we have to see things in 10 to 15 minutes with the patient, they are the history examination, making a quick diagnosis and advising investigations in 5 minutes, and with those help of those we can reach to the final diagnosis. So some fact that I have observed in my resident, and when I was resident also during the study, that diagnosis is easier than providing treatment. When now I am teacher and I see the people doing mistake, it is not like that. Treatment is easier than making a diagnosis. Why? Because treatment is based on the finding of all investigation that we do during the workup for the diagnosis. So, but how it goes, I will just try to explain it in a further slides. So the methods and approaches. So methods, benign and malignancy history is almost similar. Components are all similar: negative history, positive history. So what mistake we do in history, which I have observed, that we ask this risk factors, and maybe sometimes we miss the risk factor and we miss to correlate them, because we do not know what are the risk linked with that factor, maybe 2 to 4% in the general population, like smoking, occupation history. Some occupation has a risk of particular cancers, or some drugs have a particular malignancy, like that. Then coming to examine, so history should be in detail, maybe quick, but in detail, and we should identify some specific questions to each patient. There should be some pro forma in each person's mind. while examining the patient is also similar. We examine general examination, patient comes to the OPD, we see local examination, and then we see systemic examination, just like a Das and PJ Mehta as described in our MBBS period. So what mistake we do in examination, we do not know, but or do, but say in flow, like just one examination, we have case presentation. One student said that ki examination I elicited distress sensation. When I asked, he did not know about that. So never say such any examination that you have never done or you have never seen. Only you read. Until if you read it, just say I have read it, I did not know how to perform it. Be honest in the examination. And or sometimes we miss the important examination of the part like abdominal mass. If we miss the knee elbow position to find out it is abdominal or retroperitoneal mass. So these are the something which also comes with the practice. And if we know, we should do always never adopt a shortcut in the OPD. Then further, then where things go differently in the benign and oncological thing, the spectrum of differential we made. Because suppose a patient coming to the abdominal pain, there is a abdominal pain means all the organs on the abdomen can cause pain. So how to do that? We should always make some differential to rule that will be based on the history examination, and the remaining differential that remains after exclusion, that will guide us to the specific investigation that may or can confirm your diagnosis. So one should have a differential diagnosis ready whenever possible, except penile cancer, which is very obvious, which penile growth. But again, what generally resident miss when diagnosis, they say it is a squamous cell carcinoma. Remember that it is the histopathological diagnosis seen by macroscopic. By macroscopy, what is the clinical diagnosis? Never in examination a person should say histopathological, just like adenocarcinoma of the prostate or adenocarcinoma of the kidney, like that. No. So it should be brought as a clinical based thing. Again, I want to highlight over here, if suppose that if you know in the exam what is the case, again, do not get biased. It is something like that. You have from the many diagnosis, you have to come to that diagnosis, even what you know. So never jump to the end. As per the common presentation of the any disease, cancers are the definitely rare than the hydronephrosis and then the stone disease. So always as a common say in the medical science, if you diagnose a rare disease, you will be rarely correct. So remember this thing. Second, evaluation. So what makes a difference in the benign and the malignancy? So in benign disease, we focus on the site of the disease and related functional changes. By that, suppose that a patient having a VUJ stone. So what we will see, we know the patient has a pain, we do sonography, and we find out there is some hydronephrosis of that side. We do CT scan KUB, and once we found there's a stone, we will not do anything further. Why? Because we know it is a benign disease, but it is not true. When we face malignant disease, site should be the focus on site of disease, as well as related functional changes, as well as systemic spread. That is known as Tnm staging. And this changes the spectrum of imaging from one organ system to the whole body evaluation in the malignancy. So whenever, even in differential diagnosis, if you have a strong suspicion of a malignancy, then try to remember or tell the whole body imaging. What imaging? We will come to next slides. So we generally rarely seeing the oncological cases, we missed this thought process that malignancy, it needs whole body imaging, not the focused one. Now coming to specific blood investigation, apart from, as I listen in the history taking, we say routine investigations, CBC, creatinine, and LFT, blah blah. The tumor markers with their half-life and their role in diagnosis, prognosis, and follow-up. That will come in later, but it is their role of the tumor marker in the malignancy. So normally in urological malignancy, you can find testicular cancer and prostatic cancer, which has a tumor markers, has a prognostications, and for the diagnosis. So remember these two things when you get a case of these two cancers. Now imaging, what makes the difference in the imaging? So just I said before, similar to benign disease, there are specific investigation benign one, just like for CTKUB stone disease, but for malignancy you need either CT scan abdominal pelvis to see Tnm stage. And what we missed to see in the imaging or the local staging, like the tissue and the nodal mass at the local staging, and the distant metastasis, chest, liver, and distance any part, and the last functional one that guide us for the planning. Suppose that any patient having bladder cancer, head and nephrosis, we will not focus on treating the cancer. We also see to save the kidney. So it is again, the treatment becomes multidirectional. This is the benefit of having a whole body scan. Suppose that in the diagnosis, patient is having a stage 4 disease, the intent of treatment also changed. It is from the curative become a palliative. So this what we miss over here, the intent of imaging, that is to find out the systemic disease status. So now each cancer, coming to the malignancy, each cancer has investigation choice, and one should not miss the role of, you should know, you cannot give all the investigation to a single patient. That may be cause overdiagnosis, and if you miss something, you will do underdiagnosis. So role of CT scan, MRI, PET in your, one should know that. And which type of CT scan, triphasic, whether you need multimuscular reconstruction, not every patient you need muscular reconstruction, MRI, multiparametric or conventional MRI, when to do, which one to do, and the PET scan, the variety of PET scan, FDG PET scan, F18 PET scan, gallium 68 PET CT scan. Again, whether you have to do PSMA, this is PET scan with contrast, non-contrast, when to do. This all you should know in a case of, if you have a doubt in a case of malignancy. Remember, still we are in the phase of diagnosis. We have not made diagnosis yet. So these all steps are only towards the diagnosis. So one must avoid underdiagnosis and overdiagnosis. When it happens, it will happen when we do not know which investigation to be done for the which malignancy. What about the biopsy? In benign disease, we rarely do biopsy. So again, in malignancy, the role of biopsy is to establish the diagnosis and to have a pathological diagnosis, what type of malignancy we are treating. So it's indications and contraindication. In some cases, biopsy is not done, just like in renal tumor. It is an imaging diagnosis. Biopsy rarely, it has a specific indications, but prostatic cancer, you need a biopsy. Bladder cancer, you had some pathological diagnosis, either urine cytology or by the TURBT, you need that. The type may be incisional, excisional, core biopsy. The extent of biopsy, like prostatic cancer, 6 core, 12 core, 24, or 2 core, it all depends. That all you should know. It gives a clue about nature. Suppose that in prostatic cancer, if the patient biopsy says about neuroendocrine tumor, there's no role of surgery or radiotherapy. There's a chemotherapy. So and again, the imaging changes from the PSMA PET scan, it becomes FDG PET scan. So again, the biopsy gives us the appropriate imaging and the treatment guide for the proper treatment. So now coming to decision making for the treatment. Now, by all these investigations, we will at least come to know which organ is diagnosis is having the cancer. Now the next part comes, what we normally miss is the decision making in the cancer. How is it? Why is it important? How is it important? Let's go see. So as now you remember that thing which I was telling, treatment is easier than making diagnosis. Is it true? I don't think so. Is it true still? So what we generally miss, and most important in oncology, which we don't have in malignant disease, is the Tnm staging, and more than that is risk stratification. It is the base foundation of any treatment decision. Remember, I am again emphasizing these two lines, Tnm staging and risk stratification, that makes the base of any treatment decision, because risk stratification gives you the prognostic idea and to counsel the patient, and again the treatment option. About that, be aware of when you ever stratify the patient like that, be aware of and, or, and any. These three words are very dangerous, because normally we miss to learn and remember these two words. Just have a look on the example of prostatic cancer. We can see the definition of low risk cancer. It is and. Until there are all three factors are present, you cannot label as a very low risk category. Again, intermediate is or. That means any one of factor is present to label as an intermediate or the high risk disease, right? So be careful about remembering this thing, and while telling in the examination, sometimes examiner can catch you about these and or. Now, treatment difference in malignancy, we have best treatment option like either primary surgery or as a part of multimodal therapy like neoadjuvant, adjuvant, radiation. Just like bladder, we do multimodal therapy, TURBT, radiation, chemotherapy. After that, maybe radical or organ sparing, and never forget the lymph dissection, its indication and the template. The most common question comes in oncology is the whether it is indicated. If yes, then what is the template? And just like a upper tract urethral carcinoma, the lymph node template is based on the site of the tumor. It is not the common from retroperitoneum to the pelvic nodes. It's the upper 1/3. It is upper 2/3. It is the pelvic. It is a retroperitoneal node. If it is a lower 1/3 is the pelvic node. So remember the indication and the template of the lymph dissection. Now about the management, you should always know about the modality, active surveillance, the surgery, open lab, robotic, radiation types and doses, brachytherapy, IBRT, IMRT, adjuvant, neoadjuvant, when to give side effects, and the chemotherapy and the thermoablation that are rarely in uro-oncology. So these things you should know in oncology. Now about the survival, again, other different than the benign disease, the survival of many types like disease-specific survival, overall survival, biochemical recurrency survival, radiological progression survival, and landmark trials of each cancer one must not miss, because in exam at last when they will not find you to catch anywhere, they will catch you on the landmarks trial. So remember that thing, how and what you should prepare in the oncological cases. So now follow up, as any disease follow up, the same are the principle to see the recurrence, to see residual functions, and see new malignancy, just like a stone disease. Whether we got new stones, we have residual stone after the ESWL or PCNL, or the new stones. So again, each cancer has a specific follow-up schedule, the procedure and imaging, which is based on the previous stratification of risk and the treatment received. So you have to learn each and every cancer, the follow-up, their treatment modality, and based on treatment modality, their follow-up schedule. Now, in conclusion, I just want to say, still I feel that diagnosis is difficult than the treatment. Always make a different diagnosis, that is essential to reach a correct diagnosis. Imaging based on choice of imaging should be based on your DD, and treatment based on risk stratification and Tnm staging, and approach and follow-up must be individualized based on the guidelines. Thank you. That's all I would like to say about this thing.
Thank you, Mahendra. So if there are any questions, Mahendra, as I introduce the next speaker, you can maybe answer if the questions turn up. So basically,
Okay.
Dr. Mahendra stressed that a good history taking, properly putting it in words, the positive history, the negative history, going ahead with good differential diagnosis in your mind, the clinical differential diagnosis, because it may be an onco case or not. But if we point out only one diagnosis, which is possible in few cases, but more than one diagnosis is necessary in many cases, and our mind should be broad enough to understand the symptoms, put them together, and arrive at multiple diagnoses in their order of importance, clinical importance. Going ahead with the investigations, do order or see your time in probably super specialty exam. What we examiners see is your capability to discuss things with the examiner and show your intelligence or show what you have learned in the last 3 years. So history taking and finishing your evaluation with imagings and everything should happen really in a good time. If you can make that, it's best. So you will have a remaining, say, 15-20 minutes to discuss with your examiner, and there you will score. Okay. There seem to be no questions. So going to our next talk, it will be on imaging, and I invite Dr. Aparna Katdare. She will enlighten us about bladder cancer imaging. Aparna is Associate Professor in the Department of Radiology at Tata Memorial Hospital, and she has very good experience in uro-oncology, as well as the topic she's speaking today on bladder cancer. Aparna, you can share your presentation. And she would tell us whatever is the radiological language jargon about and how to maybe read pathology, imaging, which many times we see one thing, we don't see the other thing. So it will be nice to hear from a radiologist who is involved in uro-oncology. She's a active part of the uro-oncology disease management group at the Tata Memorial Hospital, and my ex-colleague. Welcome, Aparna.
Thank you, sir. Thank you. Can you see my screen?
Yes, we can.
Yeah. Okay. So I was actually asking Dr. Mahendra how I should have this talk, because I somehow thought that maybe residents would be very well versed with ultrasound and CT, but I think I should start with the basics. Dr. Mahendra said that we should cover everything. So I will start with the basics of all modalities, how we go about it, and then going ahead, we'll discuss MRI in a little bit more detail, because that is something that residents may not know, and it is interesting. It's something new, but I'll be covering everything. So basically, the role of imaging in bladder cancer, as it is in any cancer, is basically initially in the baseline staging and eventually in the follow-up. So for bladder, we all know the Tnm staging, but the local staging part of it becomes very important when you are imaging for bladder cancers. And this is how it is. I'm sure all of you know, but I'll just quickly go through it. Where the T1 stage is where it is a mucosal disease, and T2 stage is where it involves the muscularis. If less than half of it is involved, it is T2. If more than half is involved, T2A. And if more than half of the muscle layer is involved, it is T2B. T3 is again T3A and T3B, where T3A is the microscopic extravesical extension, which we will not be able to see on imaging, and T3B is a macroscopic extravesical extension, which we see on imaging, often see on CT, and definitely see on MRI. And T4 is when it invades the adjacent organs. T4A is when it invades the adjacent organs, and T4B is when it involves the pelvic side wall as well as the abdominal wall. So that is T4B. So imaging plays an important role in deciding the Tnm stage and taking forward the treatment. So going modality wise, for staging in a known case of bladder cancer, a USG would not have much of a role. Yes, there have been cases where very high-end USG has shown muscularis invasion, but that, or in a frank extravesical extension maybe, but this is not the role of USG. However, USG is the first screening modality in a patient with hematuria, as you all know. So we may not know that the patient has bladder cancer, and quite often it is on the USG that a bladder mass is first detected. We use the bigger probe or the curvilinear probe, which is the lower frequency 2 to 5 megahertz probe. Obviously, you need a distended bladder, and if a patient is catheterized, then the catheter can be clamped for an hour maybe before the ultrasound exam, or sometimes saline infusion is done, but that always has the risk of introducing some infection. So you would want a naturally distended bladder. So any intravesical lesion to begin with can be echogenic or hypoechoic. Bladder cancers themselves can be echogenic or hypoechoic. But a very important thing that can be ruled out on USG very easily is the mobility of the lesion. So if it's a calculus or if it's a biggish clot, then you can just ask the patient to move on table and the lesion itself moves, and you're then pretty confident that it could be a clot or a calculus. If it does not move, again, it could be an impacted clot or calculus, but then your index of suspicion raises a little bit more. A Doppler, just put in a color Doppler. You may not even need all the measurements of the Doppler, but putting in a Doppler helps in identifying vascularity within a lesion, which then again is highly suspicious of a neoplastic lesion. You could possibly see a pedicle which is vascular, and a pedunculated lesion then is more likely to be a T1 stage lesion. And then you could exclude bladder, any debris in the urinary bladder or blood clot, because obviously they will not show any vascularity. So this is just an example. Without a Doppler, this could have been anything. It could have been some debris, or it could have been some, blood clot. Without any history, if I'm telling you this is a hematuria patient, and without these Doppler findings of color within this mass, this could have been just debris or blood clot. But the moment you're seeing some kind of vascularity within this, your radar is up and you're thinking in terms of a bladder tumor. Moving on to CT urography, obviously that's the bread and butter imaging for staging bladder cancer patients. Of course, in a hematuria patient, if you're not seeing anything on initial ultrasound and maybe even a cystoscopy, CT urogram is a screening procedure even for hematuria patients. And of course, in proven malignancy patients, it is rather the bread and butter baseline staging scan. And for follow-up of these patients for local recurrence, whether it's a cystectomy or not, and for synchronous or metachronous lesions in the rest of the urinary tract, in the pelvicoalveolar system or in the ureters, because synchronous, the 2% of patients are known to have synchronous lesions, and in follow-up, almost 3.9% are known to have metachronous lesions as well. So in that way, once it's a bladder cancer, or there's a high index of suspicion for that, then a CT urography is where it is. There is no role presently of IV urography in anything here, not even lately, not even in benign diseases like a bladder calculus. You prefer a CT urography for a lot of things. So IV urogram is getting obsolete with each passing day. Of course, CT urography, in addition to depicting the pelvicoalveolar system and the urinary system, also helps to recognize the nodal disease and distant metastasis. So what are the phases that we cover in a CT urography? We do an unenhanced study where basically the plain study, which is quite helpful in evaluation for blood clots, because those blood clots will appear hyperdense even on the plain scan and will not enhance on the post-contrast study. So you are pretty much confident that they are blood clots. Obviously, you look for calcifications and stones. That's about the unenhanced study. Then we go to the corticomedullary phase. Now this phase, now I'm talking of CT urography. That is why I'm talking about the corticomedullary phase. It's not important for urinary bladder malignancy per se, but a corticomedullary phase is extremely important if there are renal lesions suspected in a hematuria patient. It helps, again, the corticomedullary is kind of the early arterial phase. So in addition to the differentiation of the cortex and medulla, it also helps for better delineation of the arteries in case there is any renal disease involved. Of course, if there are synchronous lesions, then obviously you would want to see anything in the kidneys as well. But the corticomedullary phase for the bladder per se is not that important. The nephrographic phase, yes, that is the venous phase basically. And you see bladder lesions as, I mean, if they are tumors, you see them as enhancing lesions. Quite often you would see a bladder filled with a lot of hypodense or heterogeneous kind of contents, and you don't know whether all of it is blood or some part of it is blood and some part of it is tumor. And that is where, you know, the post contrast phase is extremely important, where it helps, you know, the bladder clot will be hyperdense even on the plane as well as the post contrast, and it will not enhance, while the tumor part of all those contents is going to enhance. So that's about that. And then the delayed phase, where, you know, sometimes smaller lesions or the flat carpet like lesions sometimes may be better detected on the delayed phase. Obviously it's a limitation of a CT that very flat carpet like lesions may not be detected even on a full bladder, but a delayed scan can help. But if you were to compare a nephrographic phase with the delayed phase, it is always the nephrographic or the venous or the enhancing phase which is more important for us as radiologists. A delayed phase will always act as an additional thing when the bladder is full, and obviously all these phases are necessary in a patient for CT. A prone study is, you know, obviously, like I said, during ultrasound, it's always easier to just have the patient change position from one decubitus to another, or from supine to one decubitus, and you can see mobile lesions such as calculi or blood clots. But even in CT, you can always have the patient get prone, and if it's a blood clot or if it is a soft calculus, sure enough, it is going to move towards the dependent part. So that is an additional thing that you can do in case there is some confounding finding. There is one method called a split bolus method. We do not do it regularly, but it's nice to know that what we do here is that the initial 50 ml contrast is given during the post contrast phase for the nephrographic phase. In the split bolus method, another 60 ml is given after 8 minutes. So 8 minutes is when you're pretty sure that the contrast in an excreting good functioning kidney has come into the pelvic-ileal system and into the ureters. If you give an additional contrast at that moment, the idea is that the contrast is in the excretory phase as well as in the enhancing nephrographic phase. So you're seeing the lesion as an enhancing lesion, as well as you're seeing what it is doing to the pelvic-ileal system and ureters, and basically the rest, you know, to look for other urothelial lesions. So that is a method that is followed at some institutes. We don't really do it. So bladder mass can present either as a, you know, diffuse kind of a wall thickening, in which case your differentials do include inflammatory diseases or infective diseases as well. So but it is important to keep in mind that it can just be like an asymmetric wall thickening as well, or it can be like an intraluminal polypodal or a cauliflower kind of a lesion, as it is seen here, or it can be a proliferative lesion which is going extending extravasically, like you are seeing here, where the uterus here is invaded by the lesion. So that it can take any forms. It can, now these are big huge lesions, but they can be just small polyps also. I'll show you a few scans later, where you know, in which cases sometimes a delayed phase helps a lot in delineating them. So it can be either ways. The limitations, as I said, bladder neck lesions. So these are lesions which are near the prostate. Now, as you go in your sections below in the prostate, you may, especially in elderly patients with enlarged prostates, it may be difficult to differentiate where the prostate is starting and where, if at all, if there is any bladder mass. So reconstructions may help in those kind of patients. And if it is a cystoscopically proven malignancy, then an MRI may sometimes help in better delineating lesions here. In flat sessile lesions, like I have said already, carpet-like lesions, it's very difficult many times in our joint clinics at Tata, we are as radiologists left just staring at the scans, and when we know cystoscopically there have been many carpet-like lesions found in the entire bladder, but the surgeons are very kind to us and say that it's okay if you don't see, because they are known to be not seen. So that is somewhere we have limitations. And this is very important to know. Now, any perivesical fat stranding, any newcomer into radiology, there's this tendency of calling any perivesical fat stranding as a T3 disease or something that is spread extravesically. And that's not true, because perivesical fat stranding can be just due to tumoral inflammation also. It can happen post cystoscopy also, in a recent biopsy also. So calling every perivesical fat stranding as extravesical extension is definitely a no-no. It should raise some amount of suspicion, but then look at the bladder lesion in its entirety. If it is just a very small lesion, appears to have a pedicle, appears to be a pedunculated intravesical lesion, then that perivesical fat stranding may not be important. And of course, you always have an MRI as an option if you want to distinguish a T2 from a T3 here. And muscle invasion, obviously MRI rules. The question here, the moot question here is, when do you actually need an MRI? You obviously don't do MRI in all bladder patients. If there is obvious extravesical extension, like the case I just showed you, where the bladder mass was invading the uterus, then you don't need an MRI. But when it is a high risk patient, or the risk stratification demands that you have to have an exact idea whether it's a T2 or T3 disease, or it's a T1 and T2 disease. In that case, an MRI really benefits a lot, and I'll show you some examples here. So it is a modality of choice for local staging. The T2 axial, corneal and sagittal sections and the diffusion weighted imaging are they are the bread and butter sequences here. Contrast imaging always is an add-on, but if there is a patient who has high creatinine levels and you cannot give a contrast, even in these patients, a T2 is a very good sequence, and diffusion weighted imaging with that, we can help a lot even without a contrast. So this is what is new in MR. Many of you may be aware. Or if you're not aware, there are many kinds of RAD system that are there. The BIRADS is there for the breast, PIRADS for prostate, LIRADS for liver, and a lot of RADs going around. This is BIRADS as a system, yet is not an official part of the ACR guidelines, American College of Radiology. So it has not graduated there, but it is a very promising system. And whether it or not it goes there, what it communicates is very important. So basically, a BIRADS is a system where you try to understand if it is a muscle invasive disease or not. So a BIRADS 1 is when it is a pedunculated lesion like this, less than 1 centimeter, where you can see a proper T2 hypointense line with a maintained integrity. When it is greater than 1 centimeter, but with a pedicle and with maintained integrity of the bladder wall, it is a BIRADS 2 lesion. In BIRADS 3, you lose the pedicle or the thickened inner layer, but the integrity of the muscularis layer is still maintained. In a BIRADS 4, you now see definite loss of that integrity, suggesting extension of the disease into the muscle layer. And BIRADS 5 is where there is obvious not just extension into muscle layer, but also extravesical extension. So basically, like BIRADS or PIRADS is to communicate from the radiologist to the treating physicians as to what is their index of suspicion that the muscle is invaded, their index of suspicion for whatever lesion that is there in the breast and prostate respectively. Similarly, for the bladder, it is the index of suspicion that the radiologist feels about any lesion invading the muscle. And once we give a virate score, it is that much easier for the physicians to understand what we feel is the issue here. So this is a very small kind of a lesion. It's almost a 7 mm kind of a lesion, and then there is this T2 hyperintense internal pedicle here. So this is a typical Virats 1 lesion, where you can see that the muscularis wall here, T2, the integrity is very well maintained. It is all a mucosal lesion. So you can say with a fair degree of confidence that this is a Virats 1 lesion where there is no muscularis invasion. This was the scan that I had shown you initially of the polypoidal lesion. You can see here that there is no way of knowing whether there is really muscle invasion or whether even here is there any extravesical extension. It's very difficult to say here. But in this patient here, when you are seeing, there is just one sagittal T2 MRI, T2 sequence that I have attached here. You can see that there is a definite pedicle, and this part here is not actually what is invading the bladder wall. It is actually the cauliflower type of a lesion that is arising from this pedicle, and the muscularis layer is pretty much maintained. So you're then pretty much sure that it's a Virats 2 lesion, and there is no intramuscular, or rather it is not a muscle invasive tumor. Now coming here, this is a something between a Virats 3 and Virats 4. I'm not seeing a pedicle, so definitely this is not a Virats 2 lesion. Whether there is a definite muscle invasion, you can see here that here there is some fraying of the T2 hypointense line. Muscle should ideally look like this. It's all uniform T2 dark. Here we're seeing something. Again, here we are seeing that there is some disruption of this T2 dark line. So I would probably feel that this is a muscle invasive cancer, and this was given as a Virats 4 lesion. However, if you were seeing something like this without anything here and a maintained T2, uniformly T2 dark line here, then you would not be wrong in calling it Virats 3 either. Eventually, this was proven to be a muscle invasive cancer. And of course, something as big as this is a mass with a definite extravesical extension, and it's a T4. The seminal vesicles are involved. If you're not sure on the T2, this is the ADC portion of the diffusion weighted imaging, where this lesion is dark, and you can see here that this part of the seminal vesicle is dark and obviously invaded. So this is a definite T4 lesion, no brainer, there's no question here, no doubt here. So that is how an MRI really helps for local staging. And just one line, the FDG PET is useful for looking for distant metastasis, especially transitional cell carcinomas are known to be a bit more, or urothelial carcinomas, or high grade bladder carcinomas also are known to have distant mets more often than say an RCC or something. So in those cases, maybe PET CT can be preferred. But again, it is not useful for local staging, because as any of you who have seen PET CT knows that the FDG accumulates in the bladder as well, and that is why the bladder anyway in all patients, the bladder is bright and lit up on any FDG PET scan. So you'll not be able to distinguish the mass from the normal contrast or the normal FDG in the urinary bladder. So it would be difficult for anyone to locally stage the disease on an FDG PET, but it's a good modality for distant meds. So with that, this is basics of bladder imaging. There's a lot more that I would have loved to discuss, but I do realize I should not bore surgeons here with just the imaging talk. So I'll end my presentation here.
Thank you so much, Dr. Aparna. That was an excellent presentation for us surgeons, as you said, right from the basics to starting the clinical bedside or easy investigation, which would be an initial one, sonography, to the various forms of CT phases, CT urography, and lastly the MRI. I think most people would have understood the finesse of all these investigations. and where they would probably use it. So I think let's go ahead with the next speaker. I invite Dr. Santosh Menon, who is professor in pathology department at the Tata Memorial Hospital. And Santosh is actually one probably and only one uro-oncopathologist, and one of the best, or the best in the country, if I say so. He is a very dear friend, colleague, and he is on various international panels, including WHO panel for uro-oncological cancer pathology. So welcome, Santosh. We don't have a long time for your introduction.
Yeah. Thank you, sir. Thank you so much for Ganesh for that.
Stop sharing.
Yeah. Okay. Is it okay if I exit the meeting, Dr. Bakshi?
Yeah. No
Thank
problem.
you so much for having me around.
Thank you so much.
Yeah.
So Ganesh, thank you for the kind introduction. Can I share my screen?
Yes, please.
I hope it is visible now.
Yes, it is. Yes, it is.
Yeah, it is visible. Good evening, everyone. In fact, it's almost good night now. Thank you, Ganesh, Dr. Shah, Mahendra, and Dr. Maheshwari for having me here. The topic given to me is prognostic biomarkers in muscle invasive bladder cancer, but I think most of the audience is students. So like as Aparna gave a background of basic things in radiology, I would like to start by giving some basics about what a pathologist should be reporting and how a pathologist forms a part of a team of management of bladder cancer. And in the end, I'll show some biomarkers. When you talk of biomarkers, they are mostly molecular markers, and that becomes a little over the head sometimes. But I'll try to give some brief overview of that also. So just a declaration, there is no conflict of interest. So if I put up the role of geopathologist in bladder cancer, I think these 4 parameters are the most important ones where a pathologist plays a very important role. So initial TRBT makes a diagnosis, gives you a diagnosis, as well as it's a therapeutic kind of a management for bladder cancer. So in that, there are certain parameters which as urologist you need to look at if your pathologist is giving you that information in the report. Surveillance, urine cytology, and biopsies are important. That's another important parameter which the pathologist helps you in management. Radical cystectomy reports direct adjuvant treatment, including post-op radiation, post-op chemotherapy, especially if the nodes are positive. So I won't be going to details. My talk will be confined to these 2. And of course, the molecular days which are coming ahead in management of bladder cancer, which is a biomarker-based individualized management. So just a word about urine cytology. What would be the approach? If you should know what are the important purposes of urine cytology. The main purpose is to detect high-grade urothelial carcinoma. So urine cytology is done and it has got high sensitivity, specificity to detect high-grade urothelial carcinoma. The pickup rate for a urothelial carcinoma of low grade is poor. The sensitivity is only up to the tune of 60-65%. So that should be kept in mind. So when you are looking at a bladder lesion, which you have picked up on radiology, and you do a urine cytology for a patient of hematuria, and if your pathologist reports that there is a positive urine cytology with urothelial carcinoma, you may almost be sure that he's probably quoting that it's a high-grade urothelial carcinoma, because that's what he's able to pick up. And there are several issues in urine tract cytology, and you have to take it always with a pinch of salt. Because of the sensitivity, accuracy, reproducibility, and most importantly, the sampling errors which can occur. So there are certain problems. It has got low sensitivity in detecting low-grade lesions. There is lack of standardized diagnostic criteria all over the world, although there is some standardized reporting now, which I'll be alluding to in a minute. And the problem in urine cytology is inadequate cellularity, cellular degeneration, because the cells are in the urine for a long time and they get degenerated. So early morning first urine sample is usually not a good sample, because the urine has been there in the bladder for the whole night and the cells are degenerated. So freshly voided urine sample in a cytology department is the best sample to look for malignant cells in a urine cytology. Some couple of pictures. This is how our normal urine cytology looks. These are little basal cells, and these are the superficial cells of urothelium which you see under. And this is the pap smear which we commonly employ to look at urothelium. In contrast, a high-grade urothelial cancer, even you can easily make out the high NC ratio. This is the nucleus, this is the cytoplasm, and the cell nucleus is very high. The chromatin is very clumped. The cells are balled up. They are piling up on each other. And this is how a high-grade urothelial carcinoma looks under the microscope. So there has been certain standardized system of cytology reporting, which is the Paris system of cytology reporting, in which there are different categories, 1, 2, 3, 4, 5, and 6. So most important categories as far as urologists are concerned are these two categories of suspicious for high-grade and high-grade urothelial carcinoma, which is reported on urine cytology. And this is the basic effort which has been made by cytologists to bring about commonality and standardization in the reporting of urine cytology. This is basically based on NC ratio, the nuclear features like nuclear membrane and hyperchromasia, and the chromatin features. So 4 features are part of Paris system of urine cytology, mainly directed at picking up high-grade urine. So another important point in urine cytology during the surveillance of a bladder cancer patient is repeated positivity in the urine cytology with a negative cystoscopy warrants an upper tract imaging. So the upper tract may be shedding the malignant cells and which come into the urine, and a repeated cystoscopy may be negative, but that should trigger an upper tract imaging or a selective ureteric cytology from both ureters, which is very helpful in picking up these malignant cells from the upper tract. Coming to issues in TURBT pathology reporting. So once you do a TURBT, we know that TURBT uses thermal cautery. So as a pathologist, what we find difficult is the cautery artifact, the fragmented material which is sent to us many times, that creates a lot of problems. This has already been shown. This is a T1 tumor which goes into lamina propria, and once it invades the detrusor muscle, it is a T2 tumor. So in a TURBT, the maximum a pathologist can give you a stage is a T2 tumor, which is a detrusor invasion in a TURBT. So this is what a report should look like in a pathology. The pathologist should tell you the grade of the tumor, whether it's a high grade or low grade urothelial tumor, whether it's a TA tumor confined to the mucosa, it's a lamina invasive tumor, or a muscularis propria invasive tumor, which is a PT tumor. A thing which is routinely missed by many pathologists is the presence or absence of urothelial carcinoma in situ. So you should insist and ask your pathologist whether urothelial CIS is present. So that is important, especially in recurrent setting. If you have a recurrent high grade, a small tumor, but you have extensive urothelial CIS, that patient may be a candidate for an early cystectomy. So that's the importance of picking one. Many pathologists don't report the presence or absence of urothelial CIS. If LVSI is present, that should be reported. And many studies have shown that presence of LVSI correlates with nodal metastasis, and some centers do even give chemotherapy based on presence of extensive LVSI. The certain things like my variant histology, I'll be coming to in a minute. So this is what Dr. Mahendra had said. We should always look at the risk stratification, and these are the different kind of methods of EAU, and there you have ERTC tables of risk stratifying tumors with low risk, intermediate risk, based on a lot of pathology features like TA, grading of the tumor, whether it's primary or secondary, and presence or absence of CIS. So these are certain parameters which on pathology will help you risk stratify the tumors, and the follow-up and surveillance and the treatment of these tumors is based on these features. A word about the different classification systems in bladder cancer. It started in 1973, where it was called as grade 1, grade 2, and grade 3. TCC, the terminology TCC is not used anymore. We use only urothelial carcinoma terminology, and urothelial as the epithelium of the bladder. And now in 2004, 16, as well as 2021, which WHO is coming up, the terminology used is low-grade urothelial carcinoma and high-grade papillary urothelial carcinoma. There is a category of punlum, which basically means, which is a category which means that it's at the very lower end of the spectrum, which is punctuated by several recurrences, but very, very low risk of progression to muscle invasive bladder cancer. So these grading, if you look at 1973 grading, there were 3 grades, grade 1, grade 2, and grade 3. Whereas in 2004, 2016, and 2022, we have only 2 grades of urothelial carcinoma, that is the low grade and high grade. And mind you, these are not interchangeable. Many of the grade 2 older classification would fall into low grade, but then there are some 10 to 20% of grade 2, old grade 2, which would form part of high grade. So these are the ones which are the dangerous, and these are the ones which the urologist is interested in, because those are the disease which progress to muscle invasive and throw up metastasis. So this is a couple of pictures to show punlump. This is how your papillary, the thing which you see under cystoscopy, looks under the microscope, very thin, elongated finger-like projections, which are called papillae, a pun lump, a low-grade tumor, and a high-grade tumor, which has got very high-grade nuclear atypia and loss of polarity. Again, this is lamina propria invasion. So this is your stroma, and this is your tumor, which is invading the lamina propria. Here also lamina propria is invaded. And so there are a lot of issues. You'll find a lot of discrepancy in different reports. This is because of poor orientation, tangential sectioning, crush artifacts, which is induced, thermal cautery, which is induced by the procedure of TURBT. Sometimes the patient is already on BCG therapy, and that causes a lot of inflammation, which obscures the morphology. And then there are other pathology which can mimic bladder cancer. Important thing to remember, if the report is PT1, then low grade is almost incompatible with this report. So if your pathologist has reported low grade and says it is lamina invasive, so there is something wrong in the report, as most of the lamina invasive or muscle invasive disease are high grade by default. So if it's a muscle invasive disease, it is by default to be considered as a high grade tumor. And it is very, very rare for a low grade to invade lamina, and it's almost next to impossible for a low grade tumor to invade a muscle. So that's the important thing to be kept in mind, and that is important. So coming to the point, what are the tumors which a urologist, urothelial carcinoma, urologist is worried about? It's the muscle invasive bladder cancer. There are certain NMIBCs which are aggressive, and then there are the high grade tumors. So these are the categories which the urologist is worried about. Coming to a little bit of discrepancy rates when we talk about muscle invasive grading, we did a study as a part of thesis in TMH. And if you look at this discrepancy rate, we had almost 40% discrepancy rate between outside and inside report between low grade and high grade. So there were 40% cases where low grade turned out became high grade, and high grade were downgraded to low grade in 23% of the cases. If you come at stage discrepancy, T2 was absent. T2 was changed into MP absent in 11.5%. T1 tumor was changed to TA tumor in 15%, and T2 was downgraded to TA in about 7 to 8% of the tumors. So there is a lot of variation in pathology reporting at places, and this discrepancy needs to be kept in mind. You have to put into perspective the clinical presentation, the radiology, your cystoscopic findings, and then you have to understand what the pathology means. And sometimes you may have to take a second opinion as far as pathology is concerned. Now, coming to the main biomarker issue, which we need to, which is part of this today's topic, is all about personalized information. So you have a bladder cancer patient, we don't know how he's going to behave, and that's where the biology and prognosis comes into action. So what information, current available information, we'll talk about it in a minute. And when to ask these tests. So these are expensive tests, when to ask them, what tissue to be used. So those are the questions which come into mind: fresh tissue, frozen tissue, or formalin fixed tissue. The cost is exorbitant on biomarker studies and unaffordable for most of the low-income studies countries, and expertise is limited. So the first question which comes to your mind is, why do you need this biomarker information or personalized information to treat bladder cancer? The point is, not all urothelial cancers behave similarly. There are certain very aggressive NMIBCs which are recurrent and which progress very fast. Another category of MIBCs might be there which do not progress much. They don't behave very aggressive, or they metastasize early. The response to NACT and BCG may be varied in all these tumors. So there may be responders versus non-responders. So all this information comes from the genetic studies and the biomarker studies in bladder cancer. And in the coming era, you will have immune checkpoint inhibitors, which have already been there in practice for quite long now. We have to select which are the best candidates for these, and all this information can be provided by biomarker information. Coming to something which is a pathological biomarker, I'll say, which under the microscope only we can pick, is a variant histology in urothelial cancer. And even in an NMIBC, that may matter a lot, because these are usually present as high stage tumors and are already muscle invasive by the time they present. So many pathologists don't report these divergent and variant histopathologies, and that has to be kept in mind. So some of these are put in front of you. You can just go through them. Important ones are micropapillary and plasmacytoid, and squamous and glandular, which are pretty common. The importance is that as high as 20 to 25% of urothelial cancer high grade can show divergent differentiation, and as high as 60 to 70%. So if you are missing out on these, if the pathologist is missing out on this, then probably they are missing out on a muscle invasive bladder cancer, and they have different presentation and response to chemotherapy, and they present at different stages. Few examples: the squamous carcinoma showing keratin pearls. It is more commonly muscle invasive, and it's very responsive to PD-L1 therapy in a metastatic setting, and that's why, and it can be easily picked up under the microscope by the pathologist. Micropapillary tumors, they have these very small papillae-like appearance within the lamina propria. They usually present with nodal metastasis. Even the presence of T1 tumor, you may have nodal metastasis in these tumors, and they can even go for early cystectomy if the pathologist calls something as micropapillary urothelial cancer. The nested variant looks very low grade, but in many times it is a muscle invasive tumor, and that should be kept in mind. And then another variant is the plasmacytoid, which has got strange pattern of peritoneal metastasis, duodenal metastasis, and metastasis all over the small intestine. We have seen a couple of cases of plasmacytoid urothelial cancer. A small cell carcinoma, chemotherapy needs to be initiated in those tumors, so that's also important. So coming to what is currently known about individuals biomarker in bladder cancer, for that you need to know the molecular pathway. This is a very complicated diagram. I don't want you to remember. The most important thing which you need to remember is there is a luminal low-grade pathway and a basal non-papillary or the high-grade pathway, which is a P53 based pathway. So there is a P53 based pathway, which is the high-grade pathway, and there is an FGFR3 pathway, which is called the luminal pathway, which gives rise to a low-grade papillary tumor. So a genetically unstable bladder cell can go into the luminal pathway and develop into a low-grade urothelial tumor, and sometimes these can go into the P53 or the high-grade non-basal or basal type of pathway, and they can directly become high-grade and invasive tumors. So these two pathways you should remember. And there have got different other markers like P53 and luminal and basal markers. So this is a study from MD Anderson, which showed that many of these P53 like tumors on molecular biomarker studies, they are non-responders and they are chemo-resistant. So there is no point giving chemotherapy to these P53 like tumors. So this kind of information in the clinic, in the routine clinic and practice, can give individualized information for treating the patients, and that's important. And as pathologists, we can pick up some basal-like tumors based on certain IHC markers like CK14 and CK15, and luminal based on CK20 and GATA3. So there are certain markers, and if you could look at the plots for disease and overall survival, disease-free survival, you can see that the P53-like and the basal-like do worse compared to the luminal-like tumors. Coming a little bit to the consensus molecular classification, which has come in a big way in recent times, I just want you to remember that there are 6 different biologically relevant molecular classes. 3 of them are luminal type, including the papillary, unstable, and non-specified. One is the stroma-rich, another is the basal-like, and one is the neuroendocrine-like. All these have got different behaviors and different prognostic connotations. And in the coming next decade, this would probably come into practice in a big way, at least for the people who can afford this kind of studies, and the treatment would be based on that. So they have got histological parameters which can be correlated. So like the basal type of molecular tumors are mostly squamous under the microscope. The luminal papillary have got a papillary histology. The non-specified have got a micropapillary histology, and the small cell have the neuroendocrine-like. And they have got a different overall survival when you plot their Kaplan-Meier graphs. These are the important clinically relevant signatures. If I want to summarize that, is that if you have a squamous or a neuroendocrine molecular signatures, you can give EGFR targeted therapies. In the recurrent luminal papillary, even though they are low grade ones in papillary, in the recurrent settings, they have got this FGFR mutations and they can be targeted by FGFR3 therapies. Squamous, as I said, are amenable to PD-L1 inhibitor therapies, and PD-L1 is not useful in luminal type and stroma-rich types. And the neuroendocrine types and luminal unstable may respond to radiotherapy. So this information will help you individualize bladder cancer management in the coming era. I think I'll skip a little bit of this and come to the end of my talk. So next time you get a report of urothelial cancer, along with the common pathology report of the grading of the tumor, the staging of the tumor, whether it's lamina invasive, muscle invasive, and whether there is presence or absence of urothelial carcinoma in situ, the multiplicity of tumors, those things, the clinical and pathology is important for your day-to-day management. But in the coming era, in the coming next decade, you have to give a thought on the molecular heterogeneity of tumor. You have to think whether the tumor is basal or luminal-like, and that may be attempted with simple immunohistochemistry in the lab. You have to remember that there are 6 consensus molecular classes and they may increase in the coming years. And then certain of them are targeted to different kinds of therapy like immunotherapy, radiotherapy, and EGFR therapy. And there are certain which may be good candidates for NACT. And in platinum ineligible candidates, you can do a PD-L1 testing, and these patients are amenable to immunotherapy. These are some of my references. I would like to thank my DMG colleagues, especially Ganesh, Gagan, Mahendra, Vedang, all with whom I closely associate in clinics. A couple of slides are from Dr. Ashwin Tamhankar, and Dr. Vinayak and Palgun have taken some slides from their journal club presentation. Thank you, Ganesh.
Thank you so much, Santosh. Thank you so much on that talk. There are no questions in the chat box, actually.
Any questions from anyone?
Hello.
So I guess a lot of points we have. Oh yeah, somebody's asking.
Somebody's asking something, I think.
Anyone? No, actually, a lot of points you have already said about how to see the pathology, how to think about it, how to go about it, and how to personalize finally.
Yeah.
So I guess we should we go to the next talk then?
Yeah, sure.
The next. Thank you, Santosh.
Thank you.
And maybe you can leave the meeting and.
Okay. Thank you for having me.
Thank you. Good night.
Good night.
So may I invite Dr. Vashishtha Maniar for his talk on chemotherapy in bladder cancer.
Vashishtha has joined. He told me that he's joining, but I'm not sure. He might be trying. Then we can, meanwhile, we can ask then Abhishek.
Okay, Abhishek. So Dr. Abhishek Ghosh, can I invite you to give your talk on risk stratification in bladder cancer?
Yes, sir. Good evening, sir. Am I audible, sir?
Abhishek. Yes, you can share the screen.
Yes, sir. In a second. Okay, sir. I hope the screen sharing is visible.
Yes, please go ahead.
Right, sir. Good evening to all the respected faculties, and thank you for inviting me. My talk will be a short talk on risk stratification in carcinoma bladder, and like most of it has already been covered by Mahendra Pal sir, Aparna madam, and Menon sir. So basically, why do we need risk stratification? So it is basically to decide the line of treatment, to give the options of treatment to the patient depending on his presentation, also for determining the risk of local, regional, and distant spread, for determining progression and recurrence, for prognostication of disease, and finally the cancer-specific survival associated with the disease. So basis, what is the basis of risk stratification? So basically we are focused on recurrence and progression in risk stratification. So the strongest predictor in CA bladder for recurrence are T staging, presence of carcinoma in situ, and tumor grade. And important predictors for progression are tumor multiplicity, size of the lesion, and prior recurrences, if any. So these are such a very these are such a very broad criteria to risk stratify a patient, and there is a warrant of an integrated approach that is required. So for that, TNM staging, as we have already seen, Mahendra Pal sir has covered it already. Our focus will be on TA tumors, which are the non-invasive papillary tumors, the carcinoma in situ flat tumors, and the T1 tumor, the subepithelial connective tissue, basically the lamina propria invasive tumors. MIBC we are not going because there is no standardized risk stratification criteria for MIBC as of now. So like we have already seen the WHO grading in 1973 and then later revised in 2004 and 2016, as mentioned by Santosh Menon sir. They have divided bladder carcinoma into 3 grades: grade 1, 2, and 3, well differentiated, moderately, and poorly differentiated respectively. This was further upgraded in 2016 as a grading system for papillary lesions also, which includes the papillary urothelial neoplasia of low malignant potential, the low grade papillary urothelial carcinoma, and high grade ones. So basically these are histological grading systems which are based on nuclear size, the polarity of the nuclear shape, chromatin distribution, and the presence of nucleoli and mitotic figures. So basically, to further, historically, we have these two most important prognostic models for risk stratification of carcinoma bladder. It is the European Organization for Research and Treatment of Cancer, which included 2596 patients, 2,596 patients in 7 clinical trials, which utilized prophylactic treatments after TUR, and the Cueto model. The Cueto model was basically a Spanish club, which included 1,062 patients, which were treated with intravesical adjuvant BCG therapy to predict the risk of recurrence and progression. So what are these basically? So these are basically these systems give scoring on the basis of various clinico-pathological findings. So in EORTC model, it is based on number of tumors, the tumor size, the T category of the tumor grade as mentioned by WHO in 1973, the prior recurrence rate, and the presence of concurrent CIS. So on the basis of these, the scores are given, and on the basis of these scores, the ranges are made for the probability of recurrence in 1 year and probability of recurrence in 5 years, and so on. The same is there with the Cueto system. The Cueto system is again based on the age of the patient, which is an extra, the gender, the number of tumors, the recurrent tumors, the T category, the tumor grade as mentioned by WHO in 1973, and the presence of concurrent CIS, which is an important factor. So basically, these were all included and given high regards in the EAU guidelines of 2021. They have given strong ratings for the use of 2016 EORTC scoring model and the Cueto scoring model to predict the risk of tumor recurrence in individual patients. So basically, there is a need to integrate these systems into the present risk stratification of NMIBC as we know it. So on the basis of that only, the EAU have graded you have risk stratified the CA bladder patient into 3 types: the low risk, the intermediate risk, and the high risk. So in the low risk tumors, these are the primary tumors, the solitary tumors, TA tumors, with grade 1, which include the low grade tumors and the punlum tumors. The size of the tumors is also included in low risk, where less than 3 centimeter size of a tumor is of low risk, and no CIS. So we should always keep in mind that wherever there is CIS, it is supposed to be high grade only, high risk only. So consequently in high risk, the tumors include T1, the lamina propria invasive tumors, the grade 3 high grade tumors as per the WHO grading, and the CIS tumors, like I mentioned, and multiple and recurrent or large tumors. Again, the size is included more than 3 centimeters. TA tumors grade 1 and 2, and in this category, all conditions must be presented together. And rest all of the tumors other than these two, what I've mentioned, are included in the intermediate risk. So this was actually further revised on the basis of additional clinical risk factors. So the WHO system was included, the Cueto and the EORTC system was regarded. Also additional clinical risk factors in the form of age of the patient, that is more than 70 years, multiple papillary tumors, and tumor diameter, like I already mentioned. So in the latest EAU guidelines, again, this has been revised into 4 categories, wherein a very high risk category has also been added. So in the very high risk category, the additional clinical risk factors are included. So basically, the very high risk tumors include the TA high grade tumors, grade 3 tumors, and CIS with all 3 risk factors: the age, multiple papillary tumors, and the tumor diameter more than 3 centimeter. The T1 tumor, T1 grade 2 tumors, and CIS with at least 2 risk factors. The T1 tumors high grade or grade 3 tumors and CIS with at least 1 risk factor, or the T1 high grade G3 tumors with no CIS but all 3 risk factors. So these are all included in very high risk factors, very high risk patients. So basically, we can summarize this as like the clinical factors which can help us risk stratify the patient. The size of the tumor, as we have already seen, the less than 3 centimeter and more than 3 centimeter of the tumor is can give us an indication of the risk of the patient. The lymphovascular invasion is a very important risk factor. the grade of the tumor is very important as given by WHO. There is some controversy, but the 2004-2016 revision is still regarded. The variant histology, variant and the divergent histology, as Santosh Menon sir already mentioned, the squamous glandular differentiation, micropapillary variant is a poor prognostic histological finding. Nested variants, lymphoepithelioma, plasmacytoid, which is important, giant cell histology, undifferentiated trophoblastic differentiation, and small cell carcinoma and sarcomatoid, which is again a poor prognostic marker. And also the presence of, clinically, the presence of unilateral or bilateral hydronephrosis is again a bad clinical factor, which indicates poor risk for a CA bladder patient. So now, as Santosh sir already mentioned, the propensity is more towards the molecular markers of risk stratification. So basically, molecular markers can be any of the 6 types, which are the microsatellite associated markers. These can be proto-oncogenes or oncogenes, cell cycle regulators, angiogenesis related factors, or extracellular matrix adhesion molecules factors, which include E, cadherin, MMP, etc. So the markers basically are all based on retrospective studies. The markers normally that are in consideration right now are P53 and Ki67, which are in intensive study right now. However, these markers have not been substantial studies which can confirm the prognostic strength of these markers, and no international guidelines are yet available for them. So basically, in conclusion, there are a few caveats to our normal system of risk stratification. As I already mentioned, there is no validated risk stratification model for MIBC that exists. Of course, clinically and pathologically, we know that a high-grade tumor and a tumor with invasion, lymph, locoregional spread is always a bad prognostic tumor. But still, there are no validated, standardized risk stratification model which exists for MIBC. Molecular markers, as I mentioned, are already still under investigation. No substantial studies have been propagated regarding their inclusion into the present model. Several retrospective studies have failed to establish a benefit of the 2004-2016 revision of the 1973 WHO grading. So, of course, the controversy still persists over there. Variant histologies are not included in the risk stratification yet, which has to be included because this gives us a very this helps us to prognosticate the tumor on the basis of our initial histopathological diagnosis only. And thus far, no tool can accurately predict a pathological response to neoadjuvant chemotherapy as it is. So other than that, the T1 system, the T1 in the TNM system, it does not actually give us a very accurate representation of how much the tumor has invaded. Like the T1 in the latest TNM system only mentions the tumor invading the subepithelial connective tissue. Like Aparna madam already said, when you see a tumor that has already invaded the lamina propria, there is no question of a low-grade tumor that can. Our radar is always towards a high-grade tumor that can take place in this situation. So because of that only the T1 risk stratification is little inadequate in that sense. So to basically stratify the patient. And again, tumor recurrence has not been included in any of the studies. So basically, the current risk stratification is of like we have seen, there are four categories, which is based primarily on the histology of the tumor, and molecular markers and T1, the variant histologies and the recurrence part. If it is included, it will help us to better prognosticate the patients as per their risk, as we already have it right now. That's about it with my talk. Thank you, sir.
Thank you so much, Abhishek. That you made a good summary of all the risk stratifications for existing ones for bladder cancer. Any questions on that from anybody? So, Gaurang sir, should we then go for the next talk?
Yeah, please. Vashishtha has joined.
Okay. So, Vashishtha joined, so it is good. I would invite Dr. Vashishtha Maniar for the next talk. It's on chemotherapy in bladder cancer as per our thing, but he would definitely talk to us about advanced bladder cancer and the utility of chemotherapy and other IO therapy or whatever we practice currently in advanced bladder cancers. So Dr. Vashisht is a director and consultant of a medical oncologist at Mumbai Oncocare Center, and he is a gold medalist in DM medical oncology from GCRI with a clinical experience of more than 11-12 years. He is currently an honorary consultant with HN Reliance and Saifi Hospital. So welcome, Vashisht.
Hi, good evening, sir. Firstly, apologies. I'm actually stuck at a place which has very limited connectivity. I'm in the side room of a ICU of a hospital. Can I share my screen, please?
Yeah.
You can share your screen.
You can share. Yeah, we can see your slides.
All right. So thank you, Gaurang sir, for having me here. My objective today is to sensitize the role of chemotherapy and I'll not waste much time, but just provide a brief overview of the current chemotherapy drugs that we routinely use and a brief overview about the role of immunotherapy and as and where it stands today. And instead of this being predominantly a theoretical discussion, I would actually try and present two cases so that students would get some reasonable perspective in how to deal with these situations in their daily lives. The reason I'm actually including case one in this discussion is because I'm very keen, and this is something that we as medical oncologists occasionally face, is complete staging. So here is a 68-year-old male with reasonably well-preserved performance status. He's a known case of superficial bladder cancer since last 4 years. He's undergone recurrent transurethral resection of these bladder tumors. They've all been superstitious spreading time, and now he again presents with gross hematuria. A cystoscopy this time reveals a proliferative lesion over the lateral wall of the bladder, and again a Trbt is done. However, this time around, it's an invasive transitional cell carcinoma with lamina propria as well as deep muscular propria invasion, classifying as a muscle invasive bladder cancer. A CT is done immediately post-operatively, which shows a post-TURBT picture with some plaque-like thickening, query residual disease with 7 millimeters of perivesical nodes. There are no liver or other visceral metastases. Is this enough in terms of staging? And does this patient really need further investigation? Does it need a PET CT scan, a bone scan, or a CT thorax? Is a question that we as a medical oncologist often ask. And hence, let us look at what the guidelines say. They say that a CTA and an MRI, these are the European Society of Medical Oncology guidelines. They mention that a CT and MRI are useful to detect enlarged nodes only if they're about more than 8 millimeters in the pelvic area and about a centimeter in the abdomen. Hydronephrosis should be taken into account as it is an independent prognostic factor for advanced bladder cancer patients. A chest CT or an abdominal scan should be performed before the patient undergoes any definitive local therapy. What is the role of PET CT scan? It's a category 2B evidence where anybody who has a clinical T2 lesion or beyond should undergo a PET CT scan. Please do not use PET CT scan to look at the local anatomy of the upper urinary tract. So just to reiterate, if you see more than 7 millimeter of perivesical nodes on the local imaging of an MR, do consider a CT thorax or preferably a PET CT scan to stage the illness. I'm sure this is probably might be a slightly biased audience because the obvious treatment for such patients would be upfront surgery if it's a early T1, T2, N0 disease. But what if the patient is not keen for surgery, and what does the evidence suggest? So the evidence suggests, this is the National Cancer Comprehensive Network guidelines, that the reason I've not probably gone beyond 2019 is because things haven't changed since then, is anybody who is a cystectomy candidate, the category 1 evidence is that these patients should receive cisplatin-based combination chemotherapy. The typical combination chemotherapy is a combination of cisplatinum and gemcitabine, or you may consider a neoadjuvant cisplatinum-based chemotherapy followed by a partial cystectomy in a select few patients. Cystectomy alone should be reserved for those who are cisplatin ineligible. We will very quickly come to the definition of cisplatin ineligibility. Concurrent CTRT in early stage bladder cancer is again a category 1 evidence to offer to patients, typically nowadays reserved for people who are either not willing or not fit for surgery. What is the take of the European Society of Oncology guidelines on that? It says that people who are platinum ineligible or not willing for surgery should consider CTRT as a definitive treatment. What are the doses that we offer for such patients? Typically, the total combined dose of CTRT is 55 to 64 gray. However, one may consider initially doing giving them 40 grays of radiation and then doing an imaging and a TURBT evaluation. If there is a complete radiotherapy, if there is a very good response, then complete the radiation, that is giving the extra 15 to another 24 gray. However, if you believe that on the imaging or the TURB on an interim evaluation, there is hardly any response, we can consider salvage cystectomy in select few patients. So what are the drugs that we use? Typically, the most commonly utilized drugs are DD-MVAC and cisplatin gemcitabine. In today's day age and world, platinum gemcitabine has become the standard of care in place of dose-dense methotrexate, vinblastine, doxorubicin, or cisplatinum known as DD-MVAC, simply because of the ease of administration, and it is equally efficacious. For people who are not eligible or candidates for cisplatin, there is no data to support a recommendation of giving them perioperative chemotherapy, and the meta-analysis suggests a survival benefit to adjuvant therapy for anybody who has more than a T2 disease. So if the patient has a pathological T3, T4, or an N+ disease at cystectomy, please give them chemotherapy. Whenever there is a chance, prefer to use neoadjuvant chemotherapy over adjuvant-based chemotherapy, since it's a category 1 based evidence based on a randomized controlled trial. Another fallacy that we see often is the ease with which one tends to replace cisplatin and carboplatin. These are one of those few indications where one should not substitute cisplatinum for carboplatinum simply because carboplatinum is inferior in the perioperative setting. Coming to another case where you have a 70-year-old male diabetic since last 20 years, has been an ex-smoker, diabetes hematuria, CT shows a 3x3 centimeter lesion on the trigone with a large bladder clot, undergoes cystoscopic clot evacuation with biopsy. It's unfortunately a high-grade invasive transitional cell carcinoma. On a systemic evaluation, he's found to have extensive secondaries, so he has pleuropulmonary metastasis with skeletal lesions at D6, D9. He has a slightly compromised heart with an LVEF about 50%. For his age, his creatinine clearance is 55. He's ECOG PS1. He happens to work in the pharma industry. And the reason I say this because when these patients come to us, they come with their adequate Google, non-Google knowledge, or sharing their reports with multiple friends and colleagues over WhatsApp. What do I offer? I have a plethora of drugs to offer to such patients. Should I offer him platinum gemcitabine? Which platinum to use? Should I offer him DD-MVAC? Should I offer him upfront immunotherapy in the form of atezolizumab, pembrolizumab, or nivolumab? Or should I just offer him best supportive care? What do the guidelines suggest? The guidelines suggest that if the patient is platinum eligible, he should receive platinum gemcitabine as the first-line combination therapy. If he is platinum ineligible, he should receive carboplatin instead of cisplatinum. So what is platinum eligibility? By definition, platinum eligibility or rather ineligibility is an ECOG performance status of 2 and or a creatinine clearance of less than 60 and or a CTCAE grade 2 hearing loss or a CTCAE grade 2 neuropathy. So if you have a patient whose ECOG performance status is 2, the creatinine clearance is less than 60 or has a grade 2 hearing loss or a grade 2 neuropathy, they are considered as cisplatin ineligible. So if this is in the neoadjuvant setting, these patients should not receive chemotherapy and should directly rather be offered surgery because they're considered as cisplatinum ineligible. If it's in a metastatic setting, use carboplatin in place of gemcitabine as metastatic palliative chemotherapy. So this patient, because he's platinum ineligible, received 6 cycles of gemcitabine carboplatin because his creatinine clearance was low. His interim scan showed a responding disease, where his pleuropulmonary metastasis has regressed, his skeletal lesions had sclerosed. The reason I've mentioned treatment tolerance is typically any patient who receives gemcitabine plus platinum-based combination post the 4 cycles expect the tolerance to really take a hit. More than half of these patients after 4 cycles will have bothersome cytopenias. They would require frequent transfusions, and their hematological tolerance really takes a hit by the time they reach their 5th or the 6th cycle. What do we do next? Now this patient has received 6 cycles of platinum gemcitabine and the disease is reasonably stable. Should we just RFA the residual few lung nodules that are there or do an SBRT? Currently, there isn't enough data to suggest that treating this disease with local therapies like RFA or SBRT translates into survival benefit. What is the role of maintenance therapy? Can we continue just gemcitabine for some patients? Yes, there is one paper published in the European Journal of Oncology which says that if you give these patients maintenance gemcitabine, there is a disease-free survival benefit of about 4 to 6 months. One of the therapies that we often use in our clinical practice is metronomic chemotherapy. There isn't enough evidence to suggest the role, but I have at least a handful of patients who post 6 cycles of platinum gemcitabine are put on various combinations of low-dose cyclophosphamide, methotrexate, celecoxib, and a good amount of these patients do. As of now, in 2021, we are in the age of immunotherapy, and there is evidence, it's a category 1 evidence of putting these patients after finishing their gemcitabine platinum on avelumab maintenance. The only drug which is currently US FDA or NCCN guidelines based approved as maintenance therapy in the first line setting is avelumab, which is a PD-L1 inhibitor. So this patient did not choose to be on avelumab because it's an expensive drug. He was on observation because since he had a lot of cytopenias, he was very reluctant for a retrial of gemcitabine. After 5 months, he, however, had progression of disease with symptomatic pleural effusion. His performance status was 2, and he was minimally symptomatic, however. So what are the options that we have for such patients? The point we're trying to cover is what do you offer as second-line therapy in patients who have progressed after gemcitabine platinum for a metastatic urothelial carcinoma. As of now, in chemotherapies, we have 2 options which are known to be useful. You can use nanosomal albumin-bound paclitaxel. The expected response rate is about 20 to 35%. If the platinum-free or gemcitabine-free interval is more than 6 to 9 months, you may consider offering them a retrial of gemcitabine with or without platinum. Immunotherapy drugs can be used irrespective of the PD-L1 status in the second-line setting. The commonly used drugs are atezolizumab, pembrolizumab, or nivolumab. So these are the drugs that we spoke about. So till 2015 or 16, except for gemcitabine and platinum, there were no drugs which were available to target metastatic urothelial cancer. Then came a plethora of immune checkpoint inhibitors, is atezolizumab, avelumab, durvalumab, nivolumab, and pembrolizumab. They are either anti-PD-1 or anti-PD-L1 inhibitors. All of them have got accelerated approval and now have level 1 to level 2 evidence also in 2021 as we stand for metastatic urothelial carcinomas. What happens beyond immunotherapy in these patients? Can we look for targetable mutations? Yes, we can do a next generation sequencing for such patients. And one of the approved agents are an FGFR3 inhibitor, an oral drug called as erdafitinib. The response rate of erdafitinib is between 20 to 30%. Another thing that I would be very keen that our urology fellows remember is that these immunotherapy drugs are not phenomenally effective as a therapeutic option. They are modestly effective. The historical response rate of chemotherapy in, say, the second line setting is about 10 to 15%. The response rates of all of these immunotherapy drugs is somewhere between 15 to 20% seen on various trials. What is the 12-month overall survival data? About 1/3 to half of these patients on immunotherapy would be alive. at the end of 1 month. This is the first Keynote 045 trial, which is a phase 3 trial, which showed a 3.4-month survival benefit with the addition of immunotherapy versus chemotherapy in previously treated advanced urothelial cancer patients. Some practical recommendations in terms of what to expect. You could have a patient whom you've treated in the past is now being managed by a medical oncologist. He's prescribed them immunotherapy drugs, and the patient comes back to you and tells you that, doc, I've been asked to take these drugs. What should I expect? The beauty of these drugs, of immunotherapy drugs, unlike chemotherapy, is the fact that typically we do not see very early responses. So you need to tell your patients that to have low expectations after the first scan. In fact, do not be surprised if after the first scan, which is typically done after 3 months of starting therapy, if the lesions appear slightly bigger or brighter on the scan. This is called a pseudo progression, and it is seen in about 15 to 20% of all of the patients who receive immunotherapy. How do we differentiate between true progression and pseudo progression? Very important to look at the clinical picture of the patient. So if the patient says that he's feeling significantly better, but some amount of these nodes are looking bigger or brighter, and he's eating better, he's gained a couple of kgs of weight, his disease-related symptoms are reducing or have become stable, these are potentially pseudo-progression on the scans. Do not chop and change your drugs, continue immunotherapy. A true progression is where a patient is significantly feeling worse. There are newer lesions. You see that the patient has lost about 3, 4, 5 kgs of weight. It's very essential to not scan a patient on immunotherapy very early. You should wait for at least 12 weeks to avoid picking up the pseudo-progression. And scans can vary based on first line or second line. So in the atezolizumab trial, the scan was performed every 3 months. In the pembrolizumab trial, they were performed every 9 weeks and then every 2 months. So you should know which drug is being offered and accordingly scan these patients. Very, very essential to understand is that these drugs are not going to dramatically alter the behavior of the disease and are at best palliative. It's also very essential in a metastatic bladder cancer to know when to stop. I have often seen patients receiving 3rd line, 4th line therapies. It's very essential to understand that the response rate of a 3rd line chemotherapy or a 4th line chemotherapy is less than 10%. And it's best to offer them good supportive palliative care rather than flog them with more and more systemic therapy. Thank you so much.
Thank you so much, Vashisht. It was an excellent presentation and nice overview for the students here. I don't see any questions in the chat box. So thank you very much, Vashisht.
Thank you so much, sir.
Yeah.
I would have been very surprised if they have questions on metastatic bladder cancer.
No, but what we thought was we had earlier clinics on up to MIBC, muscle invasive, and then we thought to cover the further advanced bladder cancer in this way with some talks, because surgical students won't be so involved with this, and they need to know all what you said actually, at least have a good idea. So thank you, Dr. Gaurang Shah, sir. Any comments you would like to make? Because I think we are at the end of our session today.
Ganesh, this was a very nice program that you had, conceptualized. And the most important thing is now we know how to go about in malignancy. So now in our clinics also we can invite all these speakers again and again to give their ideas, their views, and share their knowledge for the students. So I thank all of them, and mainly Maniar and Abhishek. Maniar was so busy, and yet he took a time to give his talk. And Abhishek, he is a student, but the way he presented, it was appearing that he is like a consultant. So otherwise, Aparna and Menon, so they are the legend. So there is no question. So thank you, all of you. And in the future also, we will invite you.
Thank you, sir.
So thank you, everybody. Thank you, Mahendra. Good night.
Thank you, Ganesh sir. Thank you, Mahendra
Good
sir.
night, sir. Good
Abhishek,
night. Good
thanks,
night.
sir.
Thank you, everybody.
Thank you.
Sir, thank you, Sodha sir.
We end today's session.
Thank you, everybody. Well done.